afternoon, and congratulations to those of you who are presenting your work today. I'm Deidre Cruz, and I'm really excited to be with you all today and to share with you a bit about my path to a career in health equity. So I really have just one objective, and that is to share today. I'm going to try to share a bit about my journey to the work that I do today. I'll share some of the work that my colleagues and I have conducted, and then I'll also share some insights on what I see as the path forward towards helping us to achieve health equity. So a little bit about kind of where I come from. So I'm originally from a fairly small manufacturing town in Southern Virginia called Danville, and I really spent all my life there prior to going off to college. I come from a really wonderful family, including my husband and daughter that are there in the middle with me, and really a family that has been marked, I think, by a lot of kind of public service, both in the professional work and the kind of community work that my parents especially have been engaged in, and that really helped to shape me as a person and also to influence the work that I would later do as a physician. I am the eldest of the grandkids on both my father's side of the family and my mother's side of the family, and while you may think that that would make me the favorite, certainly my brother and many of my cousins give me a run for that title with my grandmother, who is now 91. We have a very large family, especially on my father's side, where he has 90 first and second cousins, or 90 first or second cousins, I should say. And that makes for a lot of fun, and certainly it can make for a lot of great accomplishments that we get to see within our family, including a couple of years ago, two of my cousins became the first brothers to be drafted in the first round in the National Football League. And actually in that very same year, a group of my cousins posted a respectable performance on Family Feud. And so we really do have a lot of fun in our family. As I think about pivotal people and experiences, when I think about especially my early journey towards becoming a physician scientist, as I mentioned, I come from this large family. In addition to some of the great successes and fun that we've had, our family, like many families, particularly many African American families, has had experiences with kidney disease. And so including here on the bottom left-hand side here, my Aunt Charlotte, who was a sociologist, an academic sociologist, and did suffer from both type 1 diabetes and end-stage kidney disease. She is one of several of my relatives who was impacted by kidney disease, including kidney failure. And while at the time, especially as a very young person, I did not already have a plan of becoming a nephrologist, which I am today. But in retrospect, I think these experiences with family members certainly did shape my path that was to come. My earliest memory, if someone had asked me what I would be or what I wanted to be when I grew up, my earliest memory was that I would have responded that I wanted to be a scientist. And how that manifests as a 10-year-old or so was that I spent a lot of time in our yard, kind of looking for animals that may have sort of met their demise out in the wild and trying to understand what may have happened to them. I had a great fascination with frogs that I would find in the yard. And I was fortunate later as a kind of a middle schooler to get involved in a medical explorers club that was led by a local pathologist in our town, who had sort of put together this group to expose kids to opportunities in medicine. And really, because of such a great experience with him, and finding that he was just this generous person with his time and his expertise, my earliest sort of memory of what specialty I wanted to go into in medicine was actually that I wanted to become a pathologist. And in fact, I entered medical school planning to become a pathologist. As a medical student at St. Louis University, I did then get to have my first experiences in research, including conducting or completing a visiting research elective at Johns Hopkins, where I had the opportunity to work with Dr. David Levine and Miss Lee Bone, who are featured there in the middle, on a project called Project Sugar, which was addressing disparities in diabetes with a particular focus on African Americans living in Baltimore. And so that was really one of my earliest experiences with respect to health equity research. And it was a wonderful experience in that they were conducting community engaged research addressing health equity. And it really opened my eyes to some of the possibilities in that type of, in that field. Another really pivotal experience for me was that given the focus of my medical school on service of the underserved, we had the opportunity, many of the students there, to actually go on international trips or international electives to provide medical service in under-resourced countries around the world. And I did get to travel and spend about 5 weeks in what was then called Swaziland, or Eswatini as it's called now, which is a very small landlocked country in southern Africa. It's landlocked inside of South Africa. And it was actually there that I really got the first glimpse into what it means to have your health be socially determined, so meaning that those social factors really existing outside of an individual's own characteristics or their genetic background, all of those things, that to have your actual health outcomes shaped by these sort of social forces or societal forces. As an example, in our time, myself and the other students, in our time in Swaziland, we were treating a lot of people who had HIV infection and consequences of that. At the time, Swaziland had the third highest rate of HIV/AIDS in the world. And that disease had really ravaged the workforce there. So many young people were affected. It had impacted the number of teachers and police officers and so forth that were working and were able to work there in Swaziland. And in our clinic, what we would find is that we would often see patients who would come in to be seen, and we might diagnose them with one of the sort of opportunistic infections that was kind of related to the fact that they had HIV infections, such as tuberculosis. And there were multiple occasions where we might diagnose a woman with TB, for example, and in telling that woman, hey, you're very sick, you really need to be admitted to the hospital and be treated, time and time again, what we would find is those women would say, okay, well, I'll need to travel back home and ask my husband for permission to be admitted to the hospital. And what we would often find is that those women never, after leaving to go home and ask for permission to be admitted, they actually never would make it back to the hospital. And we could only presume that those women passed away. And that situation was because to be admitted to the hospital there in Swaziland, it did require being able to pay the bill that would sort of come after being admitted. And that was such a burden on families that there was sort of a lot of sort of discussion and consideration around whether being admitted would be warranted, and such that so many people avoided seeking healthcare because of the cost that was associated with it. And so that was really, for me, a very early glimpse into these challenges surrounding these social drivers of health. And then after medical school, I matriculated as a intern and then later resident in the Osler program at Johns Hopkins. And it was there that I, in taking some of the lessons that I learned as a medical student, then began to think about the clinical experiences that I had, the clinical encounters I had, and begin to sort of develop research questions surrounding them. And I was fortunate to have some very gracious and patient mentors who worked with me and helped me to shape some of the questions that came to mind and helped me to sort of put them into terms that could actually be testable. And including on the top there, Dr. Bernard Jarr and Dr. Neil Poe, who worked with me on really what was my very first research project, which was one that grew out of my seeing that there were many people who we saw in the emergency department during my residency who kind of landed in the ER and were told that they had kidney failure and would require initiation of dialysis during that hospitalization. And in many cases, these were people who had no prior knowledge of having chronic kidney disease. They had never seen a nephrologist. And I began to become curious about what happened to those people who were initiated on dialysis in such an urgent kind of way, in such an urgent presentation, compared to those who may have been followed by a nephrologist, for example, or closely followed by a primary care physician prior to starting dialysis, and may have been able to start dialysis as an outpatient. And so my very first research project that I was the first author on was focused on that question. It took me 7 tries to get that paper published, but ultimately it was, and it taught me a lot of perseverance around this space of research. As I transitioned on to starting fellowship in nephrology at Johns Hopkins, and then later onto faculty, I was really fortunate to be mentored by Dr. Ebony Boulware and Dr. Pete Miller, that are whose pictures are there on the bottom right-hand side. And it was really around this time that I began, through their mentorship, to understand that a person could actually be both a physician and a scientist, and that I could combine this this early desire that I had had around becoming a scientist with now being a physician, and that could really help me to shape a career. And so, as I mentioned, my journey really has been towards one of focusing on health equity and research, in particular, to help us move towards health equity. And so I think important to share one definition of health equity. And so it basically means that everyone has a fair and just opportunity to be healthier. And this certainly requires the removal of obstacles to health, such as poverty, discrimination, and their consequences, including the removal of things like powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and also removal of obstacles to healthcare. What we see in the United States is that health inequities are very costly. It's been estimated that $50 billion a year are spent as a result or as a consequence of health inequities. And it's been noted that 30% of medical expenses for racial and ethnic minorities in the United States are due to excess costs that stem from health inequities. And I think a key sort of issue that underlies what we see, is particularly when it's with respect to health inequities, is that the United States actually spends less on social services than other countries, and it's the only country that spends more on healthcare than it does on social services as an overall percentage of our gross domestic product. And so this certainly may be one of the reasons that we see some of the health outcomes and particularly some of the health inequities that we see in this country. And so as a nephrologist, certainly my focus is on kidney disease, and we see that inequities in kidney disease are tremendously profound. We know that African Americans, for example, comprise 13% of the US population, but they comprise a third of those individuals who have kidney failure. Hispanic and Native Americans are twice as likely as white individuals to develop kidney failure. And people who have low incomes are also twice as likely as those who have higher incomes to develop kidney failure. And when we think about the optimal treatment for kidney failure, that being receiving a kidney from a living donor, what we see is that African Americans, Hispanic, and Asian Americans are less likely to receive this type of kidney transplant than are white individuals. And so a number of investigators have put forward these different models, these conceptual models, to help us think about what connects having social disadvantage to having a greater risk of developing chronic kidney disease. And so on the far right-hand side, what you'll see are issues kind of surrounding uninsurance or underinsurance status, and how that can impact access to healthcare, and also both the diagnosis and the management of a number of different clinical risk factors for going on and developing chronic kidney disease, including diabetes and hypertension, as well as cardiovascular disease. In the middle, what you'll see is that discrimination and those factors that stem from it are also thought to be drivers of what we see in terms of disparities in development of chronic kidney disease and its progression. And while this is an understudied area specifically in kidney disease, what we note from other work in other health conditions like cardiovascular disease is that discrimination, or the experience of discrimination, can actually lead to chronic stress, and can lead to hormonal or neurohormonal specifically activation. And though there can be downstream impacts on that, both on the individual's behaviors and but also physical downstream impacts that again can lead to an increase in some of these clinical risk factors that we see for chronic kidney disease. And then on the far left-hand side are those issues that stem from residential segregation. And so from here, what we really are thinking about are those issues that stem from this really long-standing practice in many cities, in particular around the United States, where there's been the process of redlining, for example, which is a approach that a number of cities began taking around the turn of the 20th century, cities including Baltimore, where both Black individuals and religious minorities, including Jewish individuals, were restricted in terms of the communities in which they could get loans to purchase homes or get loans to start businesses. And this has led to there being this segregation of many of those groups in cities like Baltimore, but also really in many cities across the country. And what happens in those settings is that what we see is in those racially segregated, or residentially segregated communities, often there are issues surrounding poor housing, increased environmental toxin exposure, including air pollution. There are also there's poor quality education being offered often in those school systems, and all of those can actually really influence people's risk of developing chronic kidney disease ultimately, as well as a whole host of other health conditions. And so in our time together, what I'd like to do is highlight some of the work that my colleagues and I have done really addressing these three areas. I'll sort of briefly touch on some of that work. So when it comes to perceived discrimination and kidney function, this is really an understudied area. And in a Baltimore-based study, my colleagues and I looked at self-reported perceived racial and perceived gender discrimination across 5 distinct situations. And so those situations included in the school setting, when trying to get a job, at work for those already employed, at home, and also when seeking medical care. And we also examined a general measure of the experience of discrimination that's been developed and validated. And what we found, just to give you kind of the quick summary here, was that among white women, we found that a high level of experience of discrimination was associated with a lower level of baseline kidney function in this study. And we found that among African American women, both perceived racial and gender discrimination were linked to a lower level of follow-up kidney function in this study. One of the really important pieces of my career, or really an important, I think, approach in my career, has been that of collaborating with colleagues from different disciplines, and it's really enriched the work that I've been able to do, and also has helped me to learn and have fun as well while doing this work. And so one really wonderful collaboration has been with Dr. Sarah Zanton, who is a professor of nursing at Johns Hopkins, and she, along with some of her colleagues in nursing, developed a program called CAPABLE. And CAPABLE stands for Community Aging in Place, Advancing Better Living for Elders. And I highlight this work here because it really gets at this issue of housing and what poor housing can do, or the impact that it can have on individuals. And so in Dr. Zanton's work, they developed this program that is for low-income older adults who, in many cases, have home environmental risks. So, meaning inside of their home, there are, because of the structure of it, there are places where these older adults may be at risk for falling or injuring themselves, and also because of the way that their homes are structured, they can limit these older adults' ability to really be functional in their homes. And so this program is focused on the individual participants' strengths and deficits, and also their goals surrounding things like their activities of daily living or their instrumental activities of daily living. So including things like being able to dress themselves, cook a meal for themselves, etc. And CAPABLE is a 5-month home-based intervention that involves a nurse, an occupational therapist, and a handyman or handy worker. And what the nurse and the occupational therapist do is they do an assessment of the participant, and they work with them to set goals around how they would like to function. And then the occupational therapist provides a work order to the handy worker who makes up to $1,300 worth of repairs to support that person's functioning. What has been found is that this approach, in addition to being able to improve functioning of these individuals who participated, it's actually been estimated that it leads to cost savings in terms of Medicare cost for those individuals who are participants of such a program. And so this is the publication a couple years ago that really highlighted that this was effective at improving disability in this population, again, this low-income older adult population. So I'm specifically sharing this because through work with Dr. Zanton, we actually then developed a version of CAPABLE that was focused on people with end-stage renal disease or end-stage kidney disease. And here we called it SOCIABLE, which stands for Seniors Optimizing Community Integration, Advancing Better Living with ESRD. And we started off by conducting some focus groups of our target group that we wanted to focus on, those being older adults treated with hemodialysis who also had low levels of socioeconomic status. And through those focus groups, we identified a number of different themes in terms of considerations and concerns that these individuals had, including feelings of fatigue, lack of social support that they felt like they were receiving from family and friends, and then also a desire to live independently if able to. And we pilot tested this intervention, and we did note these improvements in physical and social functioning, and concluded that these home-based interventions like this are feasible even in this population of people treated with dialysis, and could lead to favorable outcomes in this vulnerable population. Again, people largely with low incomes who are treated with dialysis. And so this issue of housing insecurity is one that has just in general not received a lot of attention, or hasn't been studied very much in the kidney disease setting. And through work with Dr. Tessa Novick, who was a resident at Johns Hopkins in internal medicine some years ago, and then became a fellow in our program at Hopkins as well. We have done some work looking at housing insecurity and how that can set a person up to have risk of developing kidney disease. And we used, again, data from the same study that I mentioned earlier that's based in Baltimore. It's called the Handle Study, or the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study. And we looked at a question that was captured in the Handle study, and that being, are you able to afford a home suitable for you and your family? And we found through examining that question that a third of the participants in this Baltimore-based study did have housing insecurity. And then after about 3.5 years of follow-up, we found that the overall population that we examined, that around 16% of them developed rapid declines in their level of kidney function. Their glomerular filtration rate was rapidly declining. 5% of them newly developed a GFR that was less than 60, and 7% of them newly developed albuminuria during that time period. And we found that housing insecurity was statistically significantly associated with developing albuminuria, including after we adjusted for a number of different factors, but we didn't find that relationship with respect to the other outcomes that we examined. When it comes to dialysis patients and thinking about this issue of housing insecurity and really the most severe form being homelessness, this is an area that we have tried to call attention to, including through this this kind of perspective piece where we called for consideration of providing permanent supportive housing to people who have end-stage renal disease, to try to offset some of the acute care costs, like emergency room visits that these individuals may have, and the hospitalizations, given that it is just unimaginable to think about trying to manage a need for coming in, for example, 3 times a week for hemodialysis for a person who is homeless, and in other health conditions. Permanent supportive housing has been quite effective, and so this was something that we've called for. And I think that work really highlighted something that I have learned more and more about through my career, and something that if I had to do it over again, and certainly my recommendation to you all would be to try to get more informed about, and if you have an interest, get engaged in this issue of health and public policy, in that these are really important approaches to actually helping us to achieve health equity. I was very fortunate early in my faculty career to be selected as a National Academy of Medicine fellow, and through that was able to get training in health policy and sort of how health policies are made and formed, and how they then can be really ways to help us achieve global outcomes that we want to see with respect to the health of populations. And through that was able to participate in a number of different committees and other activities of the National Academy of Medicine. So turning now to this topic of nutrition, which again is one that falls in many cases under this umbrella of the impact that residential segregation can have on socially disadvantaged individuals who have chronic kidney disease. Certainly when we think about chronic kidney disease, nutrition is a cornerstone of the work that those of us taking care of patients with CKD are doing, in that we certainly advise patients around certain ways that we would recommend that they eat in order to prevent their kidney disease from getting worse or prevent them from having complications of it. And so whenever we make recommendations about food and nutrition, it certainly assumes in some ways that the person we're speaking to, the patient we're speaking to, has availability in their community to kind of get to a grocery store. It assumes they have transportation. It assumes that on balance that there's a greater presence, if you will, of healthy food options surrounding them than there are fast food restaurants and places where unhealthy foods might be being sold. Exercise and nutrition go hand in hand, and so whenever we are making recommendations around nutrition, we often will tie in a piece around exercise. And then also nutritional counseling in the setting of chronic kidney disease certainly does assume often that a person has individual purchasing power. It assumes they've got enough money to buy these foods that we are recommending. And so some of the challenges, though, that we face in this thinking about this for kidney disease or other health conditions is that healthy food availability varies in communities. And this is work by Dr. Manuel Franco, who is a faculty member at the Johns Hopkins School of Public Health, who, using data from the Johns Hopkins Center for a Livable Future, looked at the availability of healthy food. So here looking at things like fruits and vegetables and whole grains and low-fat dairy foods by location. And what the location, these locations were sort of defined by was the racial composition of the neighborhoods. And this is, so the box here indicates Baltimore City, and then the surrounding areas outside of the box, that's Baltimore County. And those communities shaded in gray are those that are where the residents are predominantly white. And in those communities shaded in white, the residents are predominantly Black. And the size of the green circle indicates the amount of healthy food availability. So the larger the size, the greater the amount of healthy food there in that community. And what they found was that, and you may note here that those green circles mostly overlie those gray shaded areas. And indeed, they found that those communities where most of the residents were white individuals, and those communities where there were higher levels of average income, household income in those communities, there was a greater amount of healthy food that was noted there. We were interested in really the individual experiences that low-income African Americans in Baltimore might have around this idea of preventing themselves from developing kidney disease through dietary changes. And we in particular sought the viewpoints of African Americans here who had a first-degree family member who had kidney failure, interested again in what their thoughts were on what could be done to help them to not have the same experience as their family member. And this was a focus group study, a qualitative research study. And what one of the participants noted was, and what we have in our neighborhoods and most low-income neighborhoods is fast food restaurants everywhere. You hardly see a farmer's market or fresh produce stand or even fresh produce in the supermarket. And as soon as you walk in the market, the first thing you see is cakes, cookies, chips, cereal with loads of sugar. And so they noted that this availability of healthy foods was a challenge, and also that unhealthy foods are more convenient to prepare or to access. And finally, they noted that these sort of dietary practices that they had were a lifelong habit that they thought would be difficult to break. Another great challenge that can have an impact on health outcomes and certainly health equity is this issue of food insecurity. And so that's defined as the limited or uncertain ability to acquire nutritionally adequate and safe foods in socially acceptable ways. And what we see is that both non-Hispanic, Black, and Hispanic individuals in the United States have a greater burden of food insecurity. And that burden tends to spike really for all groups during times of economic downturn. And certainly we saw that during the Great Recession, and we're seeing that now during the COVID-19 pandemic. This is some data from Feeding America showing the states with the 10 highest rates of projected food insecurity for 2020. And what they note is that states, for example, like Texas, they were projected to have about 18.5% of the households there experiencing food insecurity in 2020. We have looked at this relationship between food insecurity and the development of end-stage kidney disease. We did this analysis among people already with chronic kidney disease in the United States, and found that for those who did have food insecurity, they were more likely to progress, to develop kidney failure. When we went on to account or adjust for some of the factors that relate to either food insecurity or risk of developing chronic kidney disease, we were encouraged to find that when we included nutritional factors in our analysis, that we were able to explain some of that relationship that we saw. That gave us hope that if we can support through nutritional interventions, for example, people who are experiencing food insecurity, that we actually may be able to reduce their chances of developing kidney failure. And so we are currently conducting a clinical trial that's really trying to tackle some of these challenges that I highlighted. The study is called 5+ Nuts and Beans for Kidneys, and it builds upon a successful pilot study of this type of intervention. But here we're focused on conducting a 12-month community-based dietary intervention study for 150 low-income African-American participants, many of them living in food deserts, many of them with food insecurity, and all of them have hypertension, plus they have albuminuria. And we're testing whether delivery of advice around following a DASH-like diet, which hopefully all of you have heard of and are familiar with, the Dietary Approaches to Stop Hypertension dietary pattern. Plus, we're providing them with $30 per week worth of fruits, vegetables, nuts, and beans, which are potassium-rich foods. And we're partnering with a local grocer to provide these foods. And the outcome that we're focused on is reduction in loss of albumin in the urine, or urinary albumin excretion, and also improvements in blood pressure. Ours is a community-based participatory research study where we have numerous partners, including our grocer partner, ShopRite, that's featured there. In a related project, we have used a kind of I think a novel research method called Photovoice, wherein this project is led by Dr. Anika Hines. But the participants here are trained in using a camera to take pictures of their food environment. And in this case, what we have done is we've recruited people who were almost eligible to become a part of our main study, 5+ Nuts and Beans for Kidneys, but for one reason or another were not found to be ultimately eligible. And we have included them in this Photovoice project. And so here are some of the photos that have been taken through Photovoice, including this one that highlighted a vacant building and noted that discriminatory practices against Black individuals here in Baltimore don't allow them to buy lots and buildings, and that in this participant's viewpoint contributed to some of the issues surrounding the food environment as well. And then this participant who, in Photovoice, who started some years ago, started his own garden based upon something that he had seen at a store. And he noted that he and others in his community have concerns around crime and safety that sort of makes them not feel as comfortable really navigating their neighborhood to seek out food purchases. And this was an approach that he took on that has been helpful for him, really to have this home garden. We had worked with an artist recently to develop a kind of a representation of many of the themes that emerged from the Photovoice project that are highlighted here. A number of them were really themes surrounding social justice, and these participants really saw this issue of the availability of food in their communities to be one of justice and worth addressing, both towards achieving health equity, but also greater social justice in general. And so certainly this past year has been one where health equity and health inequity has been highlighted. And what we've seen in terms of the COVID-19 pandemic and also these high-profile acts of racism have had some disproportionate consequences on communities of color in particular, including those noted here, such as disproportionate grief due to loss of individuals who died from COVID-19, onto really a heightened fear of institutions, fear of violence and harassment as well, such as what we've seen for Asian Americans, I think most recently highlighted by instances that we've seen covered in the news. And, as we move towards trying to achieve equity, an important approach that my colleague Dr. Lisa Cooper and I have highlighted here in this article was that it's going to require that we really work hard to enhance trustworthiness in both healthcare and in research. A couple of avenues towards doing that include enhancing our relationship-centered care that we provide to patients. It also, and this is something that I highlighted a bit of, it also really requires that we as clinicians enhance our structural competency. And that means that we increase our awareness around many of these health inequities and societal injustices, and really re-articulate the way that we think about, why an individual person, for example, may be not adherent with a therapy or a recommendation that we make, into terms that acknowledge that that they may have structural barriers to achieving that level of adherence that we would certainly want them to have. And really together through these approaches, we will establish greater trustworthiness with patients, and this will help us to move our agenda forward with respect to health equity. And so to summarize here, health equity means that everyone has a fair and just opportunity to be healthier. Inequities in chronic kidney disease are profound. And in my view, we will achieve kidney health equity and health equity more broadly through addressing some of the needs that actually may exist outside of healthcare, including in the community setting or in the home setting, through engaging with multiple stakeholders, including patients, and also ensuring that structural competence is there in both our care delivery and also in the research that we conduct. And so I'll end there, and I would invite you all to please drop questions for me in the chat, and I look forward to responding to them. Thank you.